Before I start, I'd like to thank Professor Schoenfeld for giving me opportunity to speak here today. I appreciate this opportunity to share our research with respected members. Today, I will discuss the chronic pharyngitis with relation with autoimmunity and nervous system. Chronic pharyngitis is not widely understood condition. However, due to its possible link with immune function and central nervous system, it has been suggested that there has been relationship between pharyngitis and autonomic nervous disorders, as well as pharyngitis and autoimmune disease. In my presentation today, I will first address the characteristic of pharynx. And second, I will discuss our clinical experience on pharyngeal treatments in young women suffering from somatic symptom following human papilloma virus HPV vaccination. And finally, I will discuss the underlying mechanism involved in chronic pharyngitis and its causal relationship with functional somatic syndrome and autoimmune syndrome induced by adjuvant AGL. Now, I'd like to start by talking about immunological characteristic of pharynx. The surface of pharynx is lined with ciliated columnar epithelial cells, and secreted immunoglobulin A covers the surface of pharynx. There is abundance of lymphocytes in submucosal area, and it should be noted that a large number of lymphocytes co-located with epithelial cells. Lots of lymphocytes can be obtained by ablation with cotton swab. So, importantly, pharyngeal epithelial cells express major histocompatibility complex class II antigen, indicating their role in the antigen presentation. Because sufficient number of lymphocytes can be obtained, we can perform phenotypical analysis of pharyngeal lymphocytes. When compared with their counterparts in peripheral blood, both T and B lymphocytes are highly activated, even in healthy persons. The most notable characteristic of chronic pharyngitis is submucosal congestion. We examined the vasculature of pharynx using image-enhanced endoscopy. The vasculature in normal condition is clearly recognized. On the other hand, the vasculature of chronic pharyngitis is not apparent because of submucosal congestion and edema. And it's also been noted that This condition is prone to bleeding by ablation with zinc chloride soaked cotton swab. Now, moving to what next section. Between October 2014 and September 2015, we examined 41 patients exhibiting serious somatic symptoms following HPV vaccination. The most common symptoms are headache, general fatigue, sleep disturbance. On the other hand, pharyngeal symptoms had been noticed only less than half of patients. As a result, 34 patients were unable to attend school. Now, I'll show you the standard epipharyngeal procedure. The diagnosis and treatments are achieved by applying 0.5 zinc chloride solution to entire mucosal surface through nose with nasal swab and through pharynx with pharyngeal swab. I'd like to show you the practice of traditional epipharyngeal procedure with following video. First, zinc chloride soaked nasal swab are used, and epipharyngeal walls are repeatedly flooded in various directions. Take note of the blood stain visible on the head cotton swab. Next, entire epipharyngeal wall is scrubbed using pharyngeal cotton swab. Blood can be present when significant epipharyngitis is present. The degree of bleeding from epipharynx after epipharyngeal treatments was classified on semi-quantifiable scale into 3 categories based on the blood stain on nasal cotton swab. It is generally believed that the degree of bleeding represents the severity of chronic epipharyngitis. Although mild epipharyngitis, mild pharyngeal symptom had been noticed in only 90 patients, epipharyngeal procedure revealed that, surprisingly, all 41 patients had severe epipharyngitis, identified by severe epipharyngeal bleeding. Sixteen patients consented to hospitalization in order to intensive epipharyngeal treatments. They had been previously treated using a number of approaches, including steroids, non-steroidal anti-inflammatory drugs, sleep-inducing drug, anti-anxiety drug, vitamins, and biological products. However, their condition did not significantly improve in response to any of these interventions. Marked improvement symptom was noted in 13 of 60 patients. 4 patients eventually achieved resolution of symptom. Given the degree of impairment of quality life previously observed in these patients, the favorable effect to this treatment was quite remarkable. In the remaining 3 patients who did not respond or were minimally responsive to these treatments, a considerable post-abrasive hemorrhage remained at the end of treatment, the period, indicating ongoing aphalangitis. I'd like to show you a representative case with following video. This woman had been reliant on wheelchair for 6 months before admission. At the time of admission, she had severe aphalangitis. She could barely move her leg. On day 4, her aphalangitis improved a little bit, but she couldn't lift her leg. On day 70, her aphalangitis significantly improved. She could now begin to lift her leg, although a little. On day 80, the bleeding was not changed from previous day. She still felt severe dizziness when changing her position. On day 90, she still had mild aphalangitis. She tried to stand up for the first time in 6 months. Her core muscles were unstable because he has been nearly bedridden for so long. Eventually, she could stand unassisted. On day 41st, there was no longer any post-abrasive bleeding. She could raise up her leg with ease. On day 46, at the time of discharge, she could once again move freely without wheelchair. Her lovely smile has finally returned. Now I'd like to discuss the underlying mechanism in a patient. The extremely high incidence of severe aphalangitis and dramatic improvement of somatic function with successful treatment with pharyngitis strongly suggests that the functional somatic symptom may be related to chronic aphalangitis. Because aphalanx is rich in activated lymphocytes and considerable amount of body fluid is physiologically secreted on aphalangeal surface. It is conceivable that latent inflammation of aphalanx prone to exacerbation by adjuvant stimulus with vaccination. The interaction between immune response of aphalanx and somatic symptom may be mediated via impact upon hypothalamus, pituitary, adrenal HPA axis. Moreover, cognitive impairment and memory loss were frequently observed in a patient. So it is suggested that functional alteration is not restricted to hypothalamus, but expand to limbic system in some patients. Taken together, we hypothesize that adjuvant-induced aphalangitis and subsequent functional alteration of HPV axis and limbic system may play a central role in the development of functional somatic syndrome following HPV vaccination observed in our patients. However, among these symptoms in chronic functional somatic syndrome, the symptoms such as headache, stiffness of neck and shoulders, sore throats, cough, pyrexia, and tinnitus could be considered to be symptoms related with epipharyngitis rather than dysfunction of HPV axis. On the other hand, excessive stress often causes a worsening of chronic epipharyngitis. So we hypothesize that both epipharynx and the HPV axis limbic system influence each other, and that chronic epipharyngitis combined with interaction with HPV axis and limbic system may play a central role in the development of HU and functional somatic syndrome. Before I finish, I'd like to focus some important points. The concept of chronic epipharyngitis and its relationship with autoimmunity and autonomic nervous system were originally proposed by a Japanese otolaryngologist, Professor Horiguchi. Unfortunately, given the immature understanding of immunology, the underlying mechanism could not be identified. Thereafter, the concept of chronic epipharyngitis became lost in medicine. Chronic epipharyngitis may have an important role in the development of functional somatic syndrome and HU, and we suggest the condition of epipharynx may be worthwhile to examine in broader context of treatment of autoimmune diseases and autonomic nervous disorders, regardless of the initial cause. And finally, given that chronic epipharyngitis is not fully understood, so we think it is important to focus future research on this condition. Thank you very much for your attention.
Thank you very much. Thank you. We actually have time for one or two questions if anybody has one.
I'm just wondering if you've identified the mechanism that the vaccine induces this epipharyngitis. Is it a microbiome shift that's induced, or how does the vaccine induce this epipharyngitis? Is it a microbe shift? Is there some kind of shift in the microbes in the nasopharynx?
Maybe not infection, but epipharynx is a very vulnerable portion. It's very easy to accelerate of inflammation, such as cold weather or too much stress. And I think the adjuvant may enhance the degree of inflammation. But it's not proved evidence.
Thank you for your nice talk. Could you elaborate a little bit on the therapy that you used in your patients? The therapy of the epipharyngitis.
Will you please?
The treatment.
Choice.
The treatment that you used.
Yeah.
Could you elaborate a little bit on that?
but the question means why I used.
No, not why, but what was the treatment?
What was the 0.5 zinc chloride solution to entire mucosa surface? Yes.
You drip it?
No, no.
You just drip it on the,
No,
on the
no.
nose? Or?
There are some mechanism is suggested. That the one mechanism is ablation. So because surface of chronic epipharyngitis is the cell is damaged. So by ablation, new healthy epithelial cell grow. That is one mechanism. Ablation. Hemorrhage is. But there are some.
One more quick question, and I want to get back on time.
I just want to comment a little bit on a connection to autoimmunity and inflammation. In Danish girls, which we have been able to look at, we very often do the atopic predisposition, but also allergy to nickel and mercury. And mercury is found in amalgams, I think still used in Japan, and the nickel allergy is ubiquitous, especially in girls with earrings. So we do find this associated triggers of inflammation. Did you look for, and since esopharynx and the dental oral cavity is very nearby each other, it would be sort of interesting to look if this could be a contributing
usually perform ENT doctor, but I am internal medicine.
Perhaps you should talk to oral surgeons and dentists. That would perhaps be quite fruitful.
Thank you.